Very good. Okay, I'll start again. Thank you for joining us at ISAG. We are organizing webinars every week or so. And today we're very pleased to have two experts, two specialists from Australia. So I'll be very brief. I'm hosting this meeting with my colleague, Dr. Thomas Ryan from Trinity College Dublin. I'm Julian Mersil from University College Dublin. We're both members of ISAG. And I'll just introduce briefly the seminar, and then Thomas will introduce the speakers. Then the speakers will give us a brief talk, and then we'll have questions and answers after that. So in Europe, and including Ireland and other countries, I have a message, audio is gone. Can everybody hear me? Yeah. We have a strategy of living with the virus, whereas in other countries, they have a strategy of living without the virus. And at ISAG, we're advocating that second approach. So in the media here, we tend to hear nothing from successful countries or hear a bit about them to dismiss them. So we thought it was very important to have specialists from Australia who could tell us their strategy, how it worked, and the obstacles they encountered and how they successfully overcame them. So that's why the seminar is about, the webinar. And I'll hand it over to Thomas now to introduce the speakers, and then we'll hear from them.
From Melbourne today, I think what's to just follow on what Julian said, one of the reasons many of us on this side of the world, why certain countries were so successful in eliminating the virus, is partly because that there was coherent support for the policy from both public health and broader societal economic interests. And sort of in the spirit of that, we've got two speakers who have been working collaboratively in Melbourne. One is the Chief Health Officer of the state of Victoria in Australia, and who is Professor Brett Sutton, and the other is Dr. Stephen Duckett, who is an economist, a health economist working at the Grattan Institute in Melbourne. So the way this will work is that first I'll introduce Professor Sutton, who will then give us his overview of how they've managed the pandemic in the state of Victoria. And then afterwards, Dr. Duckett will give insights from his own perspective. And then we'll have time for questions and answers, including questions from the audience. Just to introduce Professor Sutton, Brett Sutton originally graduated from the University of Melbourne, Australia in 1993 in medicine. He also holds a Master's of Public Health and Tropical Medicine from James Cook University. He has been working in public health in the state of Victoria for many years now. For the past 4 years in the Department of Health and Human Services in Victoria. And he has been the Chief Health Officer for the state of Victoria since May 2019, so for the past nearly 2 years. And I'll introduce Dr. Duckett before he speaks, but for now I'd like to invite Professor Sutton to speak.
Thanks, Thomas. I'm trying to start my video, or can you start my video? Anyway, lovely to have the opportunity to speak to everyone. As you've said, I'm calling from Melbourne, Victoria. It's NAIDOC week here, which is a celebration of Aboriginal and Torres Strait Islander Australians. So I'd like to acknowledge the traditional owners of the land on which I'm sitting, the Wurundjeri people of the Kulin Nations, and pay my respects to elders past, present, and emerging. As I say, It's a terrific opportunity for me to be speaking to you all tonight. The story of Victoria is an interesting one. We have just really emerged from our second wave. We, like many places in the world, went through a challenging first wave from the end of February through March and April, successfully so. Australia essentially eliminated virus from that first wave across most of our jurisdictions, but Victoria was struck with the second wave just as we were emerging from our first wave. We were one of the earliest countries in the world to have an uptick and to face a second wave. But we are on our 13th day of 0 new cases today. So I think we're reasonably confident that we've gotten to effective elimination again, or at least what we talk about in terms of aggressive suppression, and being pretty confident that we are not seeing any more community transmission at this stage. We're going to see it play out, and we'll go to another level of easing of restrictions towards the end of this month, and hopefully another level beyond that into early December, so that we'll have what we would call a COVID normal Christmas. I do have just a few slides I'd like to share with you, and just speak to essentially what I would say are the Melbourne model lessons, as some people are calling it. So this is the state of play just in the last couple of weeks. So as I say, we're in a very fortunate position to basically be on a 13-day streak of having no locally acquired cases of coronavirus whatsoever in Victoria. That's come off a really pretty substantial second wave. And as I say, following a first wave that was challenging enough through February, March, April and May. Most other jurisdictions in Australia have effectively eliminated coronavirus. The one exception is a kind of grumbling low-level local cases in New South Wales. But even in New South Wales, they've now had 4 or 5 days of 0 cases. And they're also looking, obviously, to get to effective elimination. All other jurisdictions are kind of flagging only cases in hotel quarantine. In Australia, we've got a situation where we've had mandatory hotel quarantine across the country since late March, 27th of March, when our National Cabinet, which was a newly formed cabinet representing the first ministers of all of our jurisdictions, our 6 states and 2 territories, that has been the consolidated mechanism for making decisions around coronavirus for the country. We've been pretty unified in our approaches, but we have had the challenges of being a federation of states and territories. Much like the United States, in many respects, like the European Union, we have our own reasonably autonomous decision-making at a state and territory level. Each state and territory has its own Health Services Act or Public Health and Wellbeing Act, as we do in Victoria, and there are statutory powers that are held with the Chief Health Officer, as we're usually called in a jurisdiction, or Chief Public Health Officer or Director of Public Health, where that statutory position holder implements the public health directions that are effectively the laws that occur under a state of emergency to enable the things that we have enacted in order to control this virus. So some of the original public health directions that were enacted in Victoria were for us to have mandatory quarantine. So the mandatory detention, if you like, or isolation of international arrivals as they came into Victoria, and of any confirmed cases and or their close contacts could also be subject to an isolation or quarantine order. The other things that have happened with our public health directions have been all of those public health measures that we're all rather familiar with across the world, that relate to constraining mass gatherings, constraining visits to aged care and acute health facilities, the size of public and private gatherings, the constraints on certain activities such as competitive sport, and certain venues and settings. such as hospitality, gambling venues, sporting venues, all of those things that have significantly constrained the opportunities for interaction with a view to reducing transmission. We are now at a point in Victoria where we're easing. We're getting to a point where hospitality is again open. Our private and public gatherings are increasing in size, and we're moving towards a much more normal way of life and way of interacting, but only because we've gotten to that point of effective elimination. These are our two waves. On this graph, the detail might be a bit small for the bottom of this graph, but essentially that first blip shows the period through March, April, May. Our first case was on the 25th of January. Arrivals from China at that time. We had very few cases through February, but in March we started to see an uptick. And it was in late March that, as Chief Health Officers, we came together. We have a national coordinating committee called the Australian Health Protection Principal Committee, where all Chief Health Officers gathered. We gathered on a daily basis for 2 hours right through that period, and we made some significant determinations. The most critical, in my view, were that of restricting international arrivals into Australia, originally mainland China. There were no additional arrivals from there. After that time, new countries were brought into play as the epidemic took off in those countries, and that was South Korea at the time, as many might remember, and Iran. That was followed by Italy. We were slower in terms of our determination about where to go next. I think we were all in a frame of what does this really mean? Are we just holding back an inevitable tide, or do we need to include more and more countries? And can we go to a complete ban on international travel? And no one had gone to that place before in Australia. We had been faced with pandemic influenza. Many of us were thinking in a frame of pandemic influenza, which was essentially a frame of this can't be stopped. People will come in when they're asymptomatic. It always reaches every country in the world. We can buy some time, as we have done, but should we really be trying to stop all international travel with all of the consequences that we knew that would be? It meant a huge amount for tourism in Victoria, more than most other jurisdictions in Australia. It meant a huge amount for our university sector, but it was feasible and it was not inconceivable. And in the end, we got to a point where there was a national decision that all states and territories implemented that international arrivals, aside from permanent residents of Australia and Australian citizens, could not enter the country except by individual determination by our border force. And so we saw that come into play in late March, at the same time as we constrained private and public gatherings, closed a number of settings, and stopped mass gatherings from occurring. And our peak in Victoria saw just over 100 cases per day. And effectively by May into June, we were down into single figures. Many of the smaller jurisdictions, South Australia, Western Australia, that have smaller populations, had already seen the end to their daily new cases. The Northern Territory never had community transmission. The Australian Capital Territory, Tasmania, very, very minimal caseloads. It was Victoria and New South Wales as really the hubs that saw international arrivals, international students in the February-March period that had a much more substantial level of community transmission that we needed to get on top of. And we were both on track to get to those very low case numbers. As may be known to some, there was transmission from our mandatory hotel quarantine to staff and then to the broader community in Victoria. That took off really like wildfire with an effective reproduction number close to 2. And so in June, it started to tick up from actually days of 0. There were a couple of days in June of 0 new cases, but then we saw single figures, and then we saw 20s and 30s. And in the beginning of July, we got to 50, 100 cases. So we were definitively in our second wave then. We made a decision in Victoria to try and manage it through, again, applying a lockdown, but we were hoping to geographically constrain it because we knew what it meant for the economy. We knew what it meant for our health and well-being, the psychology of being in lockdown. We'd just been through a few months in our first wave. So we were trying to constrain it to a number of postcodes or local government areas in the north and west of Melbourne where the second wave really took off. It was focused in our new migrant or multicultural community, and the suburbs where that population was greatest were the suburbs where the transmission was highest and where the lockdowns first occurred, and that was over 10 postcode areas. It failed, to be perfectly frank. The reality is that people have their networks through work, they have their networks through family that go beyond those postcode areas. And we saw a spillover, a seeding beyond those postcodes. And because those other postcodes weren't under a lockdown, they took off, despite really ramping up testing, really ramping up our surveillance, really emphasising across the board for Melbourne and Victoria as a whole that we needed to reduce our interactions, that we needed to be mindful of any symptoms that were compatible with coronavirus and get tested, that we needed to do all of the behavioural things that we knew would reduce transmission, especially focused on minimising our interactions with other family members, with other households, but it continued to tick up. So our next decision point was really to go to a metro-wide, so the whole of metropolitan Melbourne. Victoria is a pretty compact state in the southeast of Australia, a population of 6.5 million. Metropolitan Melbourne is about 5 million of that 6.5 million. So it applied to most of our population and a really broad area, 100 kilometres east to west, north to south. And we went into what we called a stage 3 lockdown or stage 3 restrictions. We looked to see what the next 2 weeks would show in terms of the epidemiology, the trends turning around. And you can see on this graph, so that was instituted really in mid to late July. It continued to tick up despite those very substantial constraints of no visits to households, of closing hospitality, of reducing movements, of reducing gatherings in private and public. Towards the end of July, beginning of August, we added mandatory masks indoors and outdoors for the whole of Victoria. And we were seeing what that would show in the subsequent 2 weeks. It did slow the epidemic down. We were probably in a situation where we had an effective reproduction number just above 1, maybe 1.2 or thereabouts. With the stage 3 restrictions, the introduction of mandatory masks, it's contestable and it's very difficult to tease out all of the behavioural effects, but we think that most other behaviours in terms of mobility, in terms of macro and micro distancing, the number of interactions that people had, the extent to which they were complying with 1.5 metre distance were relatively stable. We think that the effective reproduction number tipped below 1 with the introduction of mandatory masks. There is some decent evidence that it took down the effective reproduction number by 0.25. And so that tipped us from slow growth to slow decline. But of course, we were still hitting numbers of 600-700 cases per day. That was very concerning for us because it absolutely took off in our aged care sector. Our healthcare workers were infected at an alarming rate. There was the beginning of the stresses on our acute health services. And despite the fact that it started to stabilise through that mid-August period, we introduced stage 4 restrictions because the modelling suggested to us that we would be left with 600-700 cases per day for several weeks because it was only going to go into slow decline. Our effective reproduction number was sitting at around 0.95 or thereabouts, which meant that we would have hundreds of cases a day right through to the end of the year. So our stage 4 restrictions were a much more stringent level of restrictions. It applied across, again, the whole of metropolitan Melbourne and the rest of Victoria, country Victoria, which didn't have a huge number of cases, but was continuously being seeded by those travelling from metropolitan Melbourne, was starting to tick up. So they went into stage 3 restrictions. And the stage 4 restrictions in metropolitan Melbourne were a pretty significant industry shutdown. Retail closed, primary and secondary school closed. People were constrained to exercise with one other individual. There were only 4 reasons to leave home: exercise, care and compassion or emergency reasons, essential services, or essential food. You could only go for an hour a day for exercise. You could only exercise with your household or one other person. Trips for essential food were only once a day. So it was very constrained, and it was within a 5-kilometre radius, but closer if you could be closer. That was in place for many weeks, but we did see a reasonably rapid decline, as you can see on this graph, and we went from 600-700 cases per day down to 100 or fewer cases per day by the middle of September. Our hospitalised cases were largely aged care residents who needed to be moved into acute care for their care, but there were also clearly community cases who required hospital care. The hospital system was not significantly stressed because we did act, I think, relatively early compared to some jurisdictions internationally. The last 4 weeks is a success story. We have gone from 41 new cases a week about a month ago to 24 to 6, none in the last week. Our active cases that were peaking in the 3,500 range were 90 a month ago, 5 last week, they're down to 3 as of today. No new outbreaks for the last fortnight. Our testing, in large part, I think, because there's been a really concerted communications and engagement campaign for testing, but also because we've all been, frankly, traumatised by a second lockdown, a really significant second wave. None of us want this not to succeed. And so we've all been responding to the call to test, and we've got very high testing rates by international standards and by Australian standards. Our proportion positive tests has halved week on week in the last month. It had gone up to close to 2% at the worst, still pretty good by international standards. It's now at 0 with our 0 cases. We've been measuring exposure days, so the number of days times the number of infectious people who are out in the community before they're isolating. That was in the hundreds, if not higher at the peak of this epidemic. People were not necessarily isolating at first symptoms. Many were out in the community, had a number of unique contacts before they got tested, and there were challenges with the turnaround time for testing because of the number of tests that were needing to be run and the testing capacity at one point in time. But that has slowly come down. Our contact tracing has improved, and the exposure days has significantly reduced to the point where we're at now. We have also been tracking, and it's become a bit of a well-known term in Melbourne, mystery cases, so cases of unknown acquisition, really as a marker of those chains of transmission that we're concerned about because we don't know where they've come from. It means that there are people out there who are infectious, who we haven't identified, and we can't follow the upstream contacts to understand where someone's acquired illness. And so those mystery cases might represent 5 cases that we can't identify for every 1 case of unknown acquisition that we are aware of. We've been following a fortnightly total in a rolling fashion, and we've seen that go from dozens to fewer than 10, and we were aiming for fewer than 5 before our lifting of stage 4 restrictions. We got to that point. Interestingly, the number of cases of unknown acquisition in a 14-day period has tracked very closely with the same number that we were aiming for, the number of average cases per day over the previous 14 days. So 5 unknown cases in the previous 14 days, happened more or less about the same time as we got to an average of 5 cases per day over the previous 14 days. So we've closely watched self-isolation at diagnosis because that relates to exposure days as another measure. Our testing, as I say, has been a success. It was challenging during the height of the epidemic. You know, a lot of jurisdictions internationally have struggled with the testing volumes that they've needed to get to and the turnaround times as a result of it. We are now at a point where in the last month, from the time of swab to the time of completion of interview of cases has gotten to 26 hours. So including the time to swab, to transport the swab, to get that positive result, to notify the department, to initiate and complete the interview with the case has gotten down to 26 hours. Previously, we've had times where, you know, just the time to turn around a test has been more than 48 hours. So we've tried to squeeze all of those elements that are really critical, because we know the time from symptom onset and isolation to the time of quarantine of close contacts is a really significant determinant of how you get on top of transmission chains. And so we've worked really hard for all of those elements. The time between someone becoming symptomatic and getting tested, the time that that test gets to be processed and notified, the time that notification and completion of interview, the logging of close contacts, the notification of all close contacts to ensure that they're in quarantine, and in the tail end of our second wave, the quarantining of contacts. So a second ring of contacts to get ahead of the transmission chains has been a really key feature as well. We couldn't do it at 600 cases a day because one case has 10, 20, 30 secondary contacts. But when we got down to 10 or 20 cases per day, and certainly at single figures, we were going to close contacts and contacts of contacts or secondary contacts. And that's worked really well. The hotspot areas here in metropolitan Melbourne are highlighted, and we've tried to have that important nexus between high testing rates and high transmission areas. So the north and west of inner Melbourne were our hotspot areas, and this is where we really pushed for tests. And you can see in that northeast corridor in the last 14 days, that was in the last 14 days of active cases. We really pushed there because that was our last area of household and school-based transmission. We've done pretty well in terms of the cohorts for testing as well, in terms of the proportions that they represent in the community, a decent coverage of those primary school age children, a bit of a lesser coverage for teenage children, but importantly, because the majority of our cases, confirmed cases, have been in the 20 to 49 age group, we've got good coverage for men and women in those groups. Women have been better in terms of presenting for testing, and a bit underrepresented for the 50 plus age group. A little bit surprising, but you know, the drivers of transmission in lots of ways were the younger age group, so maybe even more important that we've targeted them. That's it from me. I'm very happy to take questions of any kind. I'll leave these slides for Thomas, and there are some great links here for some important things that we've done. Modelling was really key. The stage 4 lockdown, the stage 4 restrictions were the tool to drive transmission down. But the really important work was understanding how long it needed to be in place for, what it would mean to have stage 3 and stage 4 and masks, in terms of how long they would be required, when we could go to the first level of easing, when we go to the second level of easing, when we would get to a point where we had a high level of confidence that we wouldn't get a resurgence into a third wave. We were told through the modelling that a number of 5 cases average per day or fewer, and that became our target, would be a level that we could be confident that we wouldn't see a significant chance of a resurgence in cases. If we had eased restrictions significantly at 25 cases per day average, the risk of a resurgence was much, much higher, above 50%. And at 100 cases per day, it was almost inevitable. So we had University of Melbourne modelling with an agent-based model that had the inputs of our contact tracing, what we knew about exposure days, what we knew about unique contacts, what we knew about mobility, inputted into that modelling. The agent-based model uses supercomputing to really run thousands of simulations to show you how many lead to a slow and steady movement to no transmission versus the number that kind of grumble along versus those that take off again. And that's what gave us those percentages. So it's been really critical. It was validated against some empiric data. We knew the kind of numbers that our other Australian jurisdictions got to with an ability to sustain effective elimination. We also checked against Burnett Institute modelling and other internal models that we did within the Department of Health and Human Services. So it was all validated, also against international jurisdictions like New Zealand, but also got to about, surprise, surprise, 5 or fewer average cases per day, and were able to ease and were able to get to effective elimination. We've also had some important research done with the Murdoch Children's Research Institute, MCRI here, that looked into schools. Really important lessons there, which showed us that outbreaks occur in schools. There are a number of children who got infected, but most of the outbreaks were very small. In primary schools, they were particularly small. There were a number where there was just a single teacher or a single student. And the biggest factor in containing those numbers was a response to those cases within 24 hours, 48 hours in particular. It also showed that it was not primarily a driver of transmission and case numbers in Victoria. It was a consequence of otherwise community-driven transmission. So those cases were a consequence of transmission occurring in the households and between households in the community, and the spillover was into schools. The schools were not the significant driver of transmission. A couple of important exceptions in that regard. Years 11 and 12, so older kids in Victoria, really you're looking at 17, 18-year-olds, 16, 17, 18-year-olds at the end of high school. They really did have more adult-like transmission dynamics, and there were some significant outbreaks that involved those year groups. How much occurred within the school setting, how much occurred in families or outside the school setting is debatable, but it was pretty clear that transmission was a risk in those settings. But I'll finish there, I'll stop sharing, and I'll let Stephen go, and happy to take questions after that. Over to you, Thomas.
If we can make Stephen Duckett the host, I suppose, from your perspective, that would help. And then while that's happening, I will introduce him. So Brett, that was extremely inspiring, and I'm sure there's lots of questions that people will have, but we'll wait until after Stephen's talk, and then we'll field questions for both of you. Just to begin by introducing Dr. Duckett. Dr. Duckett is a health economist that has had a long and distinguished career in both academia and also in the public sector in both Australia and in Canada. So Stephen Duckett originally graduated in economics at Australian National University in Canberra for doing his PhD at the University of New South Wales in Sydney. His academic contributions have been recognized with a higher doctorate, a Doctor of Science, from the University of New South Wales, and he's also a Fellow of the Academy of Social Sciences in Australia and of the Australian Academy of Health and Medical Sciences. Dr. Duckett worked as an academic in the School of Health Administration at the University of New South Wales from 1974 to 1983. And then he worked for a good amount of time in the public health system, particularly in the Victorian health system. And of particular note, in 1994, he was appointed by the then Prime Minister of Australia, Paul Keating, to be the departmental secretary for the Australian government in the Department of Human Services and Health. He then worked as an academic at Trobe University in Melbourne for over a decade, and has also had an international career where he spent 2 years in Canada hired by the provincial government of Alberta in 2009 as President and Chief Executive Officer of its then newly created Super Board, leading a reform agenda for the Alberta Health Services. Dr. Duckett is currently working at the Grattan Institute, which is an economics think tank, a non-politically aligned economics think tank in Melbourne, Victoria, where he is currently Health Program Director. And we're very keen to hear the economic and social perspective for how successful elimination policy was shepherded through in the state of Victoria.
Sorry about that. So thank you very much. I'm also speaking to you from the unceded lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present and emerging. What I want to do is talk to you briefly about the successes here. I'm drawing a lot on what we've published at Grattan Institute. We've done 2 reports on COVID. One somewhat prematurely, as it turned out, in June when we talked about coming out of COVID, which was at the end of the first wave, and also later on in September, October, when we were turning the corner on the second wave. Victoria is quite different from a lot of the other countries. Many countries in that July period had around 700 cases per day, new cases a day. What's distinctive about Victoria is we dropped down to 0, whereas the other countries have gone up into the thousands. So I just want to talk about a couple of things about what we did right. The first thing is Australia is not in denial, unlike, for example, the United States. And so we recognise the seriousness. And secondly, we actually did something about it. Brett has talked about what we did. Again, a characteristic of the Australian experience was that there was, following the evidence is pretty clear. Outdoor is safer than indoor, low occupancy is safer than high, and masks are safer than no masks. And by and large, that's what the restrictions policy was guided by. The third thing, and this is really important, is that the Victorian government and Brett, following Brett's advice, adopted the right time horizon. And in particular, there's been a political debate within Australia about what is the time horizon about which you evaluate things. And there's, by and large, the business community has adopted a time horizon which stretches into days, 1 week or a 2-week time horizon, that if things are looking good today, then you don't have to worry about the future. Whereas the real issue is what do you do to prevent a 3rd wave or a 4th wave or a 5th wave? And that's critically important because I think community tolerance of another severe lockdown would be very, very limited in Australia. And so one of the issues was, can we control it now during this 2nd wave so we reduce the risk of a 3rd or a 4th wave? This then led to the next policy, which is about setting the right goal, which was essentially setting a target of 0. And importantly, actually not just talking about it, but doing stuff to actually get there, including the restrictions, the testing and so on. Importantly, the public supported all of this. And so this was partly, there was this in Victoria, this daily zoo at around 11 o'clock in the morning, where the Premier got up and talked about the number of new daily cases, and then started talking about the fortnightly average, and then started talking about the mystery cases. And so we all learnt this new language. The Premier did that every day, not taking any holiday, not taking any days off, and was at the end of it looking extremely haggard. But it was, the public were behind it. here are the numbers. Queensland has just gone through a state election where the strong position of the Queensland government to control the borders, the internal borders between Queensland and the other states, was endorsed, and the government was re-elected. So you can see that over this the last few months, the public support for how the state was managing the pandemic was hovering around 70%. Similarly, in New South Wales, they had a few outbreaks, mostly from Victoria, but again, very strong support for the New South Wales leadership. And in Victoria, the government was again in that 70% up to the end of the first wave, then dropped, but still only dropped to about 50%, but is now trending back up again into the mid-50s. But I think there's strong public support, even though the evidence is there was a stuff-up that led to our second wave. But even despite that, has been consistently more or less majority support for the way the government has been handling the pandemic, including these very strong lockdowns. To give you an understanding, Victoria is the coffee capital of the world, probably. It's a place where it's more or less compulsory to go out to dinner in a nice little restaurant on a regular basis. I've been outside my apartment for a meal in a restaurant 5 times since February. So it is really a significant change to the way Melburnians live. So as I said, we took steps to get there. There obviously has been significant impacts on the vulnerable. I haven't got data here about mental health, but significant increase in mental health consultations. What I've got here is the employment impact, significant impact, especially on young people. Partly casual jobs in hospitality and tourism just vanished. Retail also had a downturn. So young people in particular affected by the reduction in employment, and similarly women, a dramatic reduction in the, well, that's a 10% reduction because of the scale I've got there in employment, but particularly amongst women. There were a number of strategies pursued by government to mitigate the effect on the vulnerable. Because of our federation, there were different levels. So economic support, there were subsidies to industries to keep people in employment, even if your income had dropped dramatically. And there was also support from the state government for people to be paid while they were waiting for test results and while they were in self-isolation, because many people that were impacted were in precarious employment and didn't have award provisions which would allow them to continue getting any money, and so they would be obviously at risk of going back into the potential to transmit while they were waiting test results or while they were in isolation. In addition to the support payments, there were also business stimulate payment, which helped the return of the economy. And so if I just briefly, this is various measures of employment, and you can see that different states, the different lines of different states, there were these dips in this in the first wave here, but the economy pretty quickly returned to normal after the end of the first wave in those states which had achieved 0 transmissions. But then with the Victorian lockdown, it then reduced the level of employment again. This is consumption. And also similarly, there were impacts on mobility. You can see the differences between Sydney, which didn't have a lockdown in the second wave, and Melbourne. and so significant reductions in mobility. And again, we're coming out of that as we speak, but you can again see that there's a fairly quick return as the lockdown restrictions are lifted. But importantly, even though lockdown restrictions are still in, there are few lockdown restrictions in Sydney, there's still a reduction in activity. Of course, part of the reduction in walking is associated with winter months, but you can still see that even though there are no restrictions on walking or public transport in Sydney, there's still a self-imposed set of restrictions that are in play. And of course, what we know from the international evidence is that those countries which have managed the pandemic better, at least in that first wave up till September, have also had the best economic outcomes. And so there does seem to be a relationship between the impact on the economy and the deaths that are occurring in those communities. So there's no conflict between a policy which is about protecting the economy and a policy which is about protecting the public health. That's a quick overview to leave time for questions.
Thomas, do you want to go ahead?
Yeah.
Thanks, Stephen.
So from here, we're going to take questions, but we're trying to arrange it so that both speakers can be visible. So Julian, can you please, if you're the current host, can we do that?
I'm not sure. I think I can only make one. So I'll make anybody. I'll make whoever is talking host. That's all I have access to. I can ask a question, right, Tomas, if you want. There's one here coming in. Should I go ahead?
Yes, please do.
Yeah, perfect. Thanks to both of you. There's a question that came in the Q&A, and it actually is my question that I wanted to ask you, one of the many, about borders. In Ireland, we have a peculiar situation with Northern Ireland and the Republic of Ireland in the south. And a lot of people are saying, we can never reach zero COVID. It's impossible because the border is so open and we can't close it because of political symbolism or whatever. So we cannot reach zero COVID. So do you think that it's possible to achieve zero COVID with a somewhat open border? And if not, how could you manage that kind of special border in Ireland?
I'm happy to have a go at that, Julian.
Yeah.
Look, the borders in Australia haven't closed to each other routinely, but we've had borders closed between Western Australia, South Australia, Northern Territory for many months through this pandemic. The border between New South Wales and Victoria hadn't closed for over 100 years, but New South Wales closed its border to Victoria when Victorian cases took off. So it's unprecedented, but it was necessary. I would have done the same as New South Wales in their situation. It was very difficult for the border communities, but it did allow New South Wales to manage the very few cases that they had without the continued seeding from Victoria. Now, I won't pretend to have any understanding of the Good Friday Agreement and the complexities of the border on the island of Ireland, and indeed between Northern Ireland and the rest of the UK, but you don't have to get to 0-0. You have to get to sustainable low levels. Some kind of quarantine would need to occur if there is a hotspot, for example, in Northern Ireland, if there isn't synchrony in the control measures there with the Republic of Ireland. So if people were moving into Northern Ireland and back across, some kind of either rapid testing regimen or home quarantine or stricter quarantine arrangements would need to be in place to control that if the risk is greater there. One of the other solutions, though, is to have really good synchronisation of the lockdown measures across that border. Now, that doesn't seem to be in place at the moment, but I think that's an alternative solution. But if that's not in place, you do need to manage the risk of continued seeding and continued importation. And if that's quite high, you do need to have people quarantined, especially for the first 7 days, but ideally for the 14 days. Australia has done it for very strict measures for all international travellers for that 14-day period, with testing on day 3, testing on day 11. You pick up early cases and you can manage them as cases on day 3. On day 11, you pick up people who might just be developing illness, sometimes very mild or asymptomatic illness, as they're about to leave quarantine, and you stop people from being able to downplay their symptoms and get out of quarantine when in fact they're just becoming a case and are infectious. So some kind of quarantine, I think, is required, but you don't have to have 0. You just have to have low enough numbers that you can manage the cases that you see with a very aggressive contact tracing mechanism, the contacts of contacts potentially, and with a ramping up of testing capability through pooled testing, through innovative gene expert testing, through antigen testing to pick up the most infectious cases in order to manage the few numbers that you have. But 0 is not the only goal that you can pursue.
Thank you. Thank you, Brett.
Stephen, do you want to add to that?
Sorry, no, thank you. That's fine.
Okay, so just to follow up on that particular question, I think a lot of people will have some general questions about the overall program that allowed you to do this, because from start to finish, it was extremely comprehensive, starting with having a standpoint that was not allowing any denialism. But while we're on the subject of comparing to the situation in Ireland, one thing that is distracting, I think, from the conversation is that the way that we're perceiving the New Zealand situation. And to many people, it seems that once you get to an effective elimination, or in the case of New Zealand, absolute elimination from the community, that it becomes a fragile piece of glass that is easily destroyed. And a lot of people seem to have this perception that once you get a couple of cases entering the community, that in order to maintain an elimination situation, one would then have to lock down for a month or two, and that this would lead to a very insecure situation. And when we look at the Australian situation, that's probably not a fair description of the New Zealand situation, but when we look at the Australian situation, that's not what we see at all. We don't see that in Queensland, and even now it doesn't seem to be the attitude in Melbourne. So I wonder, could you comment on how you can pragmatically maintain effective elimination and the benefits that go with it, with having an open society and an open economy, in a way that would be generally implementable on a day-to-day basis? I'm not talking about borders, I'm talking about just managing the general community.
Stephen, do you want to start, or are you
Yeah,
happy for me
well, my view, the difficulty is, so New Zealand, one of the issues in Australia was, even at the time when we were peaking in terms of transmissions in Victoria, we could look to other jurisdictions close to us which were at 0. Western Australia, South Australia, Queensland, Tasmania were all at 0. All of whom had border controls. New Zealand had border controls. The border controls failed in New Zealand, but they got their outbreak under control fairly rapidly with fairly minimal restrictions. And so the critical thing, as Brett said right at the beginning, that we did was border control for international transmissions. And so because we're an island, because New Zealand were islands, they were able to control the influx, and then just I think the New Zealand Director General of Health, said the issue is not actually is not being at zero, but being able to identify where any of the outbreaks can occur and controlling the outbreaks. And so, yes, there's inevitably going to have outbreaks, but it's about, can you control them and stop them getting into that exponential growth that we saw with our second wave.
And New Zealand, in fact, has a community case that's just been identified this week. They're chasing it up through very, very aggressive contact tracing. They're not considering a lockdown, but as Stephen suggested, it doesn't require the whole country to lock down. It requires a focused, prioritised intervention that's finds the networks of contacts for those individuals, and a real uptick in testing across the community to find anything else that might be out there. But you know, the illustration I've made on Twitter is that Switzerland got to 3 cases on June the 3rd. So they then got to 10,000 cases a day. What is the alternative to keeping aggressively on top of very small numbers? Otherwise, you're just looking at a lockdown that happens regardless, and it happens either because it's government-imposed restrictions, or it's the restrictions that happen because there is so much transmission in the community that people stop moving around, and that economic activity gets highly disrupted by the huge pressures on the health system.
Okay, just a brief follow-up on that. I wanted to ask about the testing situation in Victoria. Very impressive numbers. So even now, you're doing 105,000 tests per week with 0.01% positivity, which I think, given the circumstances, is extremely impressive. And at the worst part in the pandemic, you said you were at 2% positivity. So by way of contrast, right now in Ireland, where we are leading Europe in bringing our second wave under control, we are testing, our testing has declined to about 70,000 per week, and our positivity rate even now is about 3 to 4%. Which is probably not ideal. We could be using that capacity for serial testing of high-risk places. We could be using that capacity for airport testing, which we're only starting to look at in a serious way. So I wonder what your comments are on how important do you think having a high testing capacity is in your experience for different stages of managing a second wave and when you're coming out of it, and how well coordinated in terms of speed is your testing situation with respect to informing local public health management, including the issue of how quickly somebody can get a test if they have any symptoms?
Yeah, I think it's been really important. As I said, we need, like many jurisdictions, we need to work through a process of ramping up the capacity across, especially our private laboratories. In the beginning, it was our reference laboratory, Victorian Infectious Disease Reference Lab, that was the second lab in the world after Wuhan, to be able to sequence the virus and to develop bespoke testing for the PCR test. I think one of the key enablers in Victoria is that there is virtually no part of metropolitan Melbourne that is more than 10 kilometres away from a testing site, whether it's a fixed site, a pop-up site, general practice, or other setting like an emergency department. People don't have to go far to get tested. The other element is that we haven't moved to a sense of complacency, and maybe that's part of what's happening in Europe, including in Ireland. And we have had the taste of elimination, and Victorians have seen it in the rest of Australia. And so part of the motivation for testing is that really, golden objective of seeing it disappear. And so I think whenever we've used a call to arms to get people tested, we've used that carrot of, this is what we will use to find every last chain of transmission and end it when we identify it. So I think that's been a key element as well. Our private labs in particular have just scaled up the human resource investment that they've made, working 16-hour days bringing more people online, getting more equipment. That's been supported by government federally and at a state level. So a real ramping up of capacity, but mostly enabling through making it easy.
Can I ask a question, Thomas, from the Q&A and my own as well? Whenever in Europe or anywhere really we talk about elimination or dealing with the virus, we are constantly bombarded with the business sector, the hairdressers, the restaurant owners, the pub owners who are all over the airwaves, and they're never happy with lockdowns. Can you elaborate a little bit more in Australia how the business community reacted, if they had to be taken on board, or if they, you know, were happy to go with it because they thought maybe one good lockdown at the beginning will save us the trouble down the line? It's really a mystery to me and to many people how to deal with that community.
I just might start. The business community was totally and completely myopic. They could only see the immediate response. I mean, I live in the central business district, right downtown, and you know, lots of places were closed, so you could actually see the significant impact on business. However, and business was by and large opposed to every measure and wanting everything to be opened the next day. But this was not the population view, and in any event, at least my view, 70 to 80% of the restrictions were a self-restriction. People didn't want to get infected, and so even though the government, if the government lifted the restrictions tomorrow, people would not have been opened up. I mean, you could see the same thing in England, where they, you know, opened up the restaurants and then had to bribe people to go to restaurants. I mean, it was the same thing here, that there was a very strong support for restrictions and what they benefit. So business, I think, was out of touch with what the views of the community were. And in any event, as I said, the evidence seems to be that a tougher lockdown creates business certainty, and the absence of a third or fourth or fifth wave is actually in the long-term interests of business. So this myopic view, I think, was myopic.
And has it changed now? Are they now, do they agree they made a mistake, or are they still saying it would have been better not doing it? Or
yeah, the day after the government lifted restrictions, they said, "Oh, you should stop having us wear masks." And I thought, come on, who cares? I mean, really.
Okay, thank you.
One thing on that subject that was notable about the New Zealand situation was that very early on, the public health community got business to be on board with early action. What makes Victoria different, of course, is that it had the second wave that was out of step with the rest of Australia and, of course, New Zealand. So did you find it more difficult to persuade leaders in the business community and indeed the Victorian government to pursue the aggressive suppression goal? I mean, it's obviously important to have a goal of zero. Selling it as aggressive suppression towards a goal of zero makes it seem more palatable, I suppose, to politicians. But I'm just wondering, did you find that more challenging because of the second wave? And what would you suggest to the rest of the world, in Europe, in North America, who are dealing with their countries that are dealing with their own second waves now?
I mean, I would say that you know, there was some reflection from the business community about Victoria not succeeding in keeping extremely low levels and getting to effective elimination after the first wave, right at a point where there were really significant calls to open up more rapidly, to allow us to see our mums on Mother's Day, to be able to move around the state. And there's probably some regret, I hope, or I expect, from many of those voices that called for that, seeing what we moved into, not just because there was a decision around further restrictions through the second wave, but because it's pretty clear internationally that whether or not the government applies those restrictions, economic activity is hugely constrained by the levels of illness and the levels of transmission that occurred. I note that Devi Sridhar has tweeted recently a study on that suggests that government-imposed restrictions contribute about 12% to the reduced economic activity, and the remainder relates to the disease itself. And I think that's starting to filter through. And I think, again, the illustration in Australia is that we've got Queensland, Western Australia, South Australia that are going back to mass gathering events, big sporting events, normal retail activity, normal Christmas activity that is so advantageous for the economy, and we can't afford to be grumbling along with fighting a significant level of transmission continuously, because we will never be able to get to the level of lifting of restrictions that we're aiming for now. We are aiming for, outdoor gatherings of 500 people, indoor gatherings of a couple of hundred people in early December. So I think, there is some reflection on just what that means. From my part, I would say that there was very good support at a state government level for that narrative and for that objective, and it was seen for what it was.
Thanks. I have another audience question, which is the question that a lot of people are asking within the 2 seconds or so of the news about the vaccine earlier this week. People were saying, well, that's it. We don't have to follow the zero COVID guys because, the vaccine is going to come soon. Sure, not tomorrow, but soon. So just let's drag ourselves through, the lockdowns and yo-yo or whatever strategy. Would you still do the same thing as towards an elimination strategy, whatever the vaccine news are, or would you change it now because it's more positive on that front?
Oh, I think a vaccine is still effectively 6 months away for high level coverage. If we had gone down a path where we had really significant transmission, it would have taken 6 to 9 months to be able to turn those dynamics around. I think we're at a point where we've got such low level transmission now that if there's a hotspot, the small initial allocation of vaccine for Australia will be able to manage the healthcare workers, aged care workers, quarantine, hotel staff, first port of entry staff, and potentially hotspot areas to completely stop the transmission, the low levels of transmission risk that continue. If we had very widespread transmission, we wouldn't have gotten 100% vaccination coverage available in Australia until the second half of next year. That is a long time in the world of coronavirus. And as we've all seen, you can move from cases in their dozens to cases in their tens of thousands within a 1 or 2 month period. And so, that is not a reason to give up on aggressive suppression now, I think, because you'll be facing tens of thousands of cases in a short period of time, and the vaccine will not come in to save you from that.
I suppose the acid test for this is how quickly countries that have an elimination scenario open up their borders in advance of the vaccine being widely available. I don't see any countries doing that currently. So one question that I have about the overall picture of the system is the importance of isolation, which I think is missing, apart from lacking a strategy in many European countries. We tend to be not investing very much on isolation itself. And if one is to use the Thomas Puyo kind of ontology of the 4 levels of Swiss cheese that one uses to control how the virus spreads, first it's level 1 about getting into the community. Then it's social restrictions, the most extreme of which is lockdown in category 2. Category 3, contra-infection, wearing masks, hygiene, physical distancing. And then category 4, the isolation of infected individuals. Test, trace, isolate, colloquially. Levels 2 and 3, the middle 2 levels, we're doing generally quite well in most European countries. European countries are really good at level 2, which is lockdown. And we're pretty okay at level 3. And many European countries, including Ireland, have a very good testing capacity, although it may not be very quick or coordinated enough to be useful to public health. We also have some confusion as to how effective testing and tracing is with respect to the total number of cases in the community. But it seems to me that the crucial features on either extreme of this 4-stage process is the isolation aspect, which is that when you're testing and tracing people, it's only relevant if that information is working for isolation, and those people are required to isolate and are supported to isolate, neither of which is happening in many European countries. And on the other, on level 1, about isolating people as they are coming into the country. And what's been very impressive about Australia and New Zealand and other countries too is the mandatory quarantine for 2 weeks that everybody has to undergo when they come into the country. Now, obviously, these two things come at a significant cost. But what we've learned in Europe in the second wave is how many countries have been severely affected by new variants of the virus that have been seeded since the second lockdown. So we know now that controlling borders is evidently a way to do it. I suppose my question then is, what do you feel is the economic cost of having this 10-day to 2-week quarantine that you have in Australia and will likely have until the end of this pandemic? Second part of that question is, do you see this being replaced with a sort of a testing fence as is being experimented with in Hawaii, where you would have a 3-stage test system that, if well organized, would be as effective potentially as a 10-day to 2-week hotel quarantine?
So can I just comment?
Go for it.
Thanks, Brett. There are 2 significant groups which are impacted by the border controls. The first is international students. Sorry, I should say, one of the things is the massive reduction in the total number of arrivals. So New South Wales, I think, has a daily cap of maybe 850 arrivals a day, when it used to be 850 people on a single plane. Not quite true, but you know, just a massive reduction in the number of arrivals, partly driven by the limitations on organising the quarantine. But so there's 2 groups that are affected in Australia. One is international students. We have a very big international student industry in this country, and the international students have basically collapsed. However, 2-week quarantine for an international student is insignificant if they're going to be here for 3 years. So it is possible, if we can organise the capacity to actually manage the quarantine of international students, to actually restart the international student market, which has a significant impact on the economy. The second group are international tourists. However, 70% of Australian tourism income is domestic tourism. And so it is not as big an impact as you might think, even though we get lots and lots of tourists. A lot of our tourism is domestic tourism. And if you're lazy enough to watch TV in Australia at the moment, I'd say every 3rd ad is an ad to go to New Zealand because of the potential travel bubble with New Zealand. So, you know, the domestic and travel bubble tourism is the way of addressing that. So the capacity, the international quarantine is a big issue, but I think over the next few months, we're going to have to get our act together on what is the future of international quarantine and how is it going to be managed. And I have a personal interest in this. My daughter is in London, about to come back to Australia in a couple of weeks' time. She has tested COVID positive. And the question is, well, what does that mean when she arrives here? If she's got antibodies, you know, what's the policy going to be about whether she has to do the 2-week quarantine and so on. So it's we really need to think some of these things through.
And I'd add, Stephen, that nationally we're looking at other models that might not be quite so expensive as hotel quarantine. They might be hybrid models. They might be entirely home-based. They will probably use a country of origin risk stratification so that people coming from countries of very low risk, Western Pacific countries, Taiwan, mainland China now, Hong Kong, even South Korea, combined with home quarantine, probably have the same risk of introducing a case into the community as someone coming from the United States who has strict 14-day hotel quarantine. So I think there are some models that we can explore that are cheaper, that are more home-based. But even with our positive cases in Victoria in the last few months, we did daily in-home door knocks using Australian Defence Forces to assist us with the human resources required there. There are whisper apps that prompted people to remain in quarantine. And I know that there's technology that's being explored now, not just the electronic bracelets that I know Hong Kong is using, but also some geolocating iPhone-based videos where you can basically confirm that someone is where they say they are. I mean, one of the issues with home quarantine is that you can ensure that someone hasn't left the home, but you can't ensure that there's no one else around who's visiting them. So there's always some weakness with a home quarantine model, but testing is one way to give you greater assurance that you're picking up true cases in the community.
Thanks. Thomas, can I ask you a question that's been really present on the feed here? Well, there's two really. One is the question that the world is asking, the world with COVID, should we cancel Christmas? What should we do with all those returning travelers and families meeting? Everybody's asking this in Ireland and elsewhere. And the other one, which is separate, what should we do with the schools, primary, high school, in order to get towards a zero COVID? Do we have to close them? Do we have to have models of hybrid teaching or whatever? So two separate questions, but it's all over the place here in Europe and in Ireland.
Yeah, I mean, I think the evidence around transmission in younger children has been mixed. It's not entirely clear what the effect of school closures are. The Murdoch Children's Research Institute research that was done, I think, has been useful in the Victorian context to show that primary schools were not a driver of transmission, and that, you know, maybe if we had our time again, we could keep those primary school settings open. I think we need a genuine consideration about the older age groups in high school, and it's either going to remote learning for, you know, children maybe 12 years and above, maybe 15 years and above, or to have really significant mitigations in the school setting, and attestation of being free of symptoms, reducing the density of children within classrooms, really embedding ventilation, ensuring hygiene, compulsory mask wearing for teachers, except when they need it for the purpose of teaching, and for all students, and making sure that there's good symptom surveillance and exclusion of anyone who's developing symptoms at school. So I think all of those things means that we probably don't need to go to an immediate, you know, remote learning across the board for schools. On the issue of Christmas, look, it's more a philosophical question. Well-being and meeting your family are intertwined, and around the most significant events, it's even more critical. We've missed out on so much in Victoria. The prospect of not meeting for Christmas would crush us, I think. I would rather say, make sure that the genuine super spreading events are mitigated to the fullest extent possible, and have communications around anyone who's symptomatic getting tested before they're visiting somebody else. And even, you know, working through the idea of having masks in indoor spaces, bringing ventilation into your home settings, and ensuring that you can create the spaces between people, the distance outside of the hugs, and the time that you spend together. There is plenty of evidence that you can do a lot of mitigation without, you know, meaning that you can never see your loved ones, which I think is a really significant health and well-being factor, obviously.
Stephen, do you want to add to Christmas strategies, or?
I just said in the chat that it's summer here, don't forget, and so you can be well ventilated and outside.
Yeah. Someone was asking, someone from our group actually was asking, we talked about border restrictions, from outside, but what about the border or movement restrictions within Victoria, within the state of Victoria, which is applicable, of course, to Ireland with the border with the north, but also within the Republic or within, I'm from Canada, within provinces. It's very similar to Australia. So can you talk about what strategies were employed in that regard?
Yeah, because we had our second wave commence in metropolitan Melbourne out of hotel quarantine, which is where those hotels were, the cases really took off in metropolitan Melbourne before they started to seed into regional Victoria. And so when we introduced the stage 4 restrictions for metropolitan Melbourne, we did have a setting of stage 3 restrictions in regional Victoria, but they were more liberal. And there was some appeal in going to regional Victoria if you're in lockdown in Melbourne. So we called it the Ring of Steel. It probably wasn't a Ring of Steel, but there were work permits that you required if you're an essential worker who needed to go to regional Victoria for work purposes. Otherwise, you were not allowed to go. The only exceptions were if your intimate partner was in regional Victoria or metropolitan Melbourne, you need to cross that boundary, or for essential work, as I said, but otherwise you would be checked and you would be turned around and potentially penalised if you were trying to get across. And it was really to stop that ongoing seeding. And regional Victoria became COVID-free 4 to 6 weeks earlier than metropolitan Melbourne because it had a lower caseload and because we stopped that ongoing seeding. So, I think it was a useful strategy to allow regional Victoria to get up and going in terms of its restrictions a lot earlier than Metro Melbourne.
We're approaching the 90-minute mark, so we'll close shortly. But perhaps we have time for 1 or 2 more questions. I suppose from a European perspective, a lot of people in a lot of countries here would like to see an aggressive suppression strategy be implemented and successful. And the counter arguments we've received, not just from business, but from government, start with, it would be awful for the economy. It would be awful for people's mental health. It's not sustainable. All of these things have been thrown at this and have been more or less diffused one by one. I think it's very much accepted that if you can have less virus in the community or no virus in the community, that's better for health and better for the economy. We're in lockdown anyway in most of Europe, so we have the most efficient means of getting there. We're paying the price. We want to get the return for that investment and not have a third lockdown. We really don't want to have a third lockdown in most European countries. And what's becoming surprising to many of us who've been advocating for an elimination model is how much of the public are on board with restrictions. So if you take Ireland as an example, as of 2 days ago, 70% of the public support the current very stringent restrictions, and another 20% of the public want stronger restrictions, which is not reflected in the media and not reflected in the government conversation. So it seems that the last line of opposition in terms of logical argument as to why an aggressive suppression towards zero strategy is not possible is because we're not Australia, we're not New Zealand, we're not Taiwan, we don't have their geographic uniqueness, we don't have the ability to do what they are doing. So it's not that it wouldn't be nice to do it, it's not that it wouldn't be beneficial to do it, it's not that we want a third lockdown, it's that we just can't do it and they can do it. And this seems to me to be a little bit silly because it seems obvious that if Australia was to behave in the way that Europe behaved, you would be in exactly the same situation as we are now. So I wonder what's your overall message to Europeans right now on how we can adapt our thinking towards an evidence-based view of making the difficult, but I think worthwhile decisions of changing how we're living with this pandemic.
Well, I'd start by saying it's this myopic question. You've got to think about what time horizon are you making a decision about? And if you're worried about the third wave and the fourth wave, then you have to really, that creates so much business uncertainty that you've got to, it drives a decision to worry about what you're doing now for the longer term, even with a potential of a vaccine in the next 6, 8, 9 months. It really is very interesting looking at the United Kingdom. You know, I thought they were an island, and I thought they actually voted to be an island. So why they didn't actually use the benefits of border control, I have no idea. But even without border control, part of your solution has to be about stopping the virus coming into the polity, basically. Because you've got it, that's right at the start of the first stage of that model. Try and protect, stop it coming in, and that also includes internal border controls as well, trying to stop it getting to regional Victoria, etc.
Yeah, I'd say there's a golden opportunity now if many countries are going through a lockdown because they have to, because they're trying to save their health systems. Now is the time to take advantage of that synchronicity across the European Union more broadly. Whether or not there can be sufficient measures on international travel to get to that 0 is for you guys to debate, but I would say synchronisation is the next best measure, and there is an opportunity to take advantage of very low numbers if they're not 0 numbers. What shouldn't happen is the syndrome that we've seen from the Czech Republic, celebrating the end of coronavirus, you know, a little bit like Switzerland, really thinking that all the work had been done and somehow the dynamics of transmission wouldn't come roaring back as they went back to a very normal way of life. New York has sustained its low numbers, and it's ticking up now, 2.5% positivity, because they maintained outdoor dining into the long term. They kept hairdressing outdoors, massages outdoors for as long as they possibly could. So I would say, if you're not in strict lockdown, continue the measures that you can sustain. If the effective reproduction number is below 1, it might take a little bit longer, but it'll continue to drive numbers down, and you will get to those sustainable figures, balancing against what our needs are as human beings for interaction. So keep the mass gatherings out, keep the sporting events out, keep the pubs and clubs and dancing gone, and come slowly back in. That really maintains a downward pressure on numbers so that you can continue to have those conversations about 0 being feasible.
Okay. Thank you very much. So we've approached time now. So we'll close this particular ISAG Inside Town Hall meeting. I'd like to thank everyone who attended. This is recorded and will be published soon on the ISAG website and on Twitter. I'd like to thank Dr. Duckett and Professor Sutton for joining us at this rather late hour in Melbourne and for sharing with us their insights and experience. And I understand that Professor Sutton, you'll be taking a well-deserved annual leave starting tomorrow. So we appreciate you making the time for us this evening. And congratulations to both of you and to all of the people of Victoria on outstanding and inspiring achievement.
Thank you, Thomas. Thank you, Julien, and thanks everyone who tuned in tonight.
Thank you.
Thank you. Is it just you and me now?